We will need one more for quorum. All right, it looks like we are meeting the quorum right now. Welcome everyone to the DUR in July. A few reminders for our meeting today. If you are dialing in via telephone, Google Hangout has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. If you are using your laptop for audio and visual during the meeting, you can control the function in the Hangout. We kindly ask that only those who are speaking to the group unmute their device. For the DUR board member, please reserve the question until the end of the presentation, or may ask in the Google Hangout meeting chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send the email to medicaidpharmacy@utah.gov. For attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or email medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after meeting to help us improve our process moving forward. Thank you. And with that, I will pass this to Dr. Smith.
All right, good morning, everybody. You able to hear me okay?
Yes.
Great. Okay, since we have a quorum, and we already had the reminder about attendance, so the next item on the agenda is review and approval of minutes. Are there any changes needed? Hearing none, is there a motion to approve the minutes?
I'll move to approve the minutes.
Thank you. I see a hand up from Kumar. Is that a second?
Yes.
Thank you. All right. All in favor of approving the minutes as written, say aye.
Aye.
Aye. Aye. Okay, great. The minutes stand approved. Okay, can we get the P&T committee update?
Yeah, there was no P&T committee meeting in June. So the last meeting was May, where we discussed the glucagon products for hypoglycemia. Those went live on the PDL July 1st. And so that's available on our website for everyone to view if they wish. Our next meeting will be in September. And in September, we'll be discussing wakefulness promoting agents. That's things like NuVigil, ProVigil, Sunosi, WakeX, and that type of product.
Sounds good. Thank you. All right. So next item on the agenda is the annual training for the Utah Open Public Meeting Act. Is Tony Patterson on?
Yes, I am. Thank you. The purpose for this training is not that the division or anyone believes that there has been a violation of the Open and Public Meetings Act. The purpose of this training is to comply with the legislature's imposition of a requirement that public bodies annually be trained on the Open and Public Meetings Act. This training should only last no more than 10 minutes, I'm hoping. At least that's what I'm shooting for, so it should not take too long. As a reminder for those individuals that may not be familiar with the Open and Public Meetings Act, the purpose for it, as expressed by the legislature, is that it is their intent that all of the state business be done in public, that it be done open, and that their deliberations be open. And for those that have had the opportunity or the displeasure to sit through some of the trainings that I've provided in the past, know that I like to turn to current affairs in order to help individuals or to help facilitate discussion regarding the Open and Public Meeting Act. So I'd like to start with a video that came up during the last year regarding the Open and Public Meetings Act. Some of you may recall it. I don't think it needs much introduction. And so for that reason, as soon as I'm able to share it, I will pull it up and hit play. Oh, I've never had that happen before. Okay.
The messages are too profane for television, but
apparently having a bandwidth issue. Well, it was a nice video clip. Let me try one thing here, and if that doesn't work, then I will skip it. Okay. Apparently there's a problem presenting that. This was the story that had to do with the Salt Lake City Board of Education. There was a member of the board who had what some people believed attempted to bully other board members. As a result of that, that initiated a public outcry. It brought attention to the board, and as a result of that investigation, it was discovered that 2 other board members were making fun of parents and making fun of staff employees. And I'm sure many of you remember the story. I believe the lessons that we can learn from this particular story is that, number one, continue to act professionally at all times. And that if other individuals are perceived that they are mistreated, it does invite investigation. And even though you may not be the member of a public body that invited that investigation, nonetheless, you can still end up being the subject of what I believe is public comment, just as the 2 other board members were, because what they had done had not come to light, but because of the request for government records, individuals became aware of how they had treated other individuals, and they themselves ended up being criticized by the media. So the takeaway, I think, from the story, in addition to continuing to act professionally, is that you need to guard your comments, whether they be verbally during a meeting, because the meetings are recorded and those recordings are published. Also, your emails, and to use when possible the state email, and if not, perhaps have a dedicated email of your own that you would be able to use, so that you could separate your private communications from your public service on the board. Now, there is another example that came up in the news this past year. There were several. I'm only going to highlight 2 because of time. The second one was in an article, "This Ruling Guts Utah's Open Records Law and Leaves Citizens in the Dark." This was a June 22nd, a relatively recent article by the Salt Lake Tribune. In it, it was addressing the issues surrounding Bridal Veil Falls, Utah County, and the commission attempting to acquire property, and of course the efforts that were being made to preserve that particular piece of property for the benefit of the public. Nonetheless, there were some comments that were made between the commission members and between certain members of the public. One of the members of the public, and I'm just summarizing for time, ended up indicating that they were in favor of a particular effort by a commission member. They later turned on that commission member and turned over some text messages. And because of that information becoming public, then another individual who took this particular issue quite seriously, was very interested in the outcome of it and the direction that it was taking, and was fearful that it was being driven by developers and not for the good of the public, submitted a government records request for all of the records. The particular Utah County Commissioner, which had a friend, he thought, that turned to foe, thought that he was shielded because that information and his text messages were private. The request was made. Utah County said, no, we're not going to turn that over to you because that's off of his personal phone. The decision was appealed to the full commission, which is the next level of appeal in Utah County. And as it so happened, the individual whose records they were requesting was the Utah County Commissioner who had committed the offense. And I say offense because it appears that he ended up being dishonest. Regardless, it went to the Records Committee on appeal from there because that commissioner refused to address the issue ever when the commission was assembled. It was interesting that the Records Committee concluded that it was his private phone and that they could not force him to turn over his phone, despite having direct evidence that he was less than truthful in reporting that he did not have any such records on his personal device. So he was able to get away with it in this incident because the individual did not appeal it to the district court. Had it gone to the district court, there could have been a different outcome. However, in this article, it pointed out that in the past, there have been instances where public officials have been required to turn over their public devices, and that those public devices were utilized. And of course, one of those was the John Swallow incident, I note of which he was eventually acquitted of all charges, but nonetheless, it caused him to give up a public office and actually shut down the work of one of the divisions within the office for about 18 months as they were busily engaged in responding to government records requests. So those two laws, GRAMA and the Open and Public Meetings Act, are closely tied. So I would like to provide just a very brief update on the legislature's business this past year. There were 4 primary bills that changed the Open and Public Meetings Act. One just recently taking effect, all of them, I guess, recently taking effect. Most of them would not have that significant of an impact going forward. One lengthy bill actually does, because it creates a new Utah Open Record Portal website and a Utah Open Data Portal website to help facilitate obtaining information about public meetings and to help coordinate requests for government records. And those changes were significant in that particular legislation. Now, as a reminder, all business is to be done in open. We should not be having conversations via text or messages during a meeting. Comments need to be made on the record. Those records and minutes will be posted. The minutes must be posted within 3 days. And just as the friendly reminder, the penalty for violation of the Open and Public Meeting Act is any decision made by the committee can and will be set aside by the court. And there's a potential Class B misdemeanor that an individual could be prosecuted for for knowingly and intentionally violating the Open and Public Meetings Act. So that is the update and refresher of the Open and Public Meetings Act this year. Thank you for your service, and I just would encourage each of you to continue every time in your professional efforts in serving the state. We are grateful for that. And as I have observed your conduct in the past, I would say the committee on a whole, or excuse me, the board on a whole has done an excellent job of being professional in your comments. And as you continue to do that, you should be able to avoid any conflict with the Open and Public Meetings Act. So if there are any pressing questions, I would be happy to entertain them at this time.
I don't have any questions, but I'd like to personally thank you for the training, Tony. In the P&T committee, we actually recently had something happen where a drug rep reached out to a committee member and wanted to meet with them privately shortly before a P&T committee meeting about the subject of the meeting. And this committee member was familiar with your training, knew exactly what to do, reached out to me, and we politely declined the request for meeting.
Excellent. That is a good way to avoid having one's name taken in vain in the press.
Tony, this is Joe with the department. I would assume that council holds for requests from patient advocacy groups too, be they diabetes care patient advocacy groups. If they wanted to meet with Dr. Hoffman to discuss some upcoming committee agenda item, your counsel would be to politely decline.
Yes. Now, Dr. Hoffman has a couple of roles with the department in addition to her role on the board. In her role, I will say up on the 4th floor, she may have to, meet with constituents and address those. However, and I've worked with Dr. Hoffman. I have a great deal of confidence in her and her ability to distinguish when it was perhaps crossing the line from her role as a member of the department versus her role as a member of the committee. And obviously, Dr. Hoffman, if you had a particular question, I would extend the invitation to you if you'd like to discuss that. That would be fine. Your role is a little bit unique from a lot of the board members because of the dual role that you have with the department.
Yeah, Tony, I just picked Dr. Hoffman as an example. I could have used Kumar, so I apologize.
Good comment, though, Joe. Thank you.
Many of us have multiple roles, as a University of Utah physician, clinical investigator, representative, public servant. I mean, we have to be so conscious of where we might have conflicts of interest, or we're representatives of our respective bodies. And I think it's always beneficial to be reminded, Tony. So again, I want to also thank you for the training, and it's always good to be refreshed on what the current considerations are, and to keep us mindful.
Well, thank you. I believe that is the legislature's intent, because it's the exception when there is a problem, right? They do come up, and so through the friendly reminders, hopefully it can be something that will be avoided. Well, thank you for that kind comment. Any other questions or comments? Well, I'm sorry you couldn't watch that very fascinating 2-minute video clip, but it worked fine last night when I did it. Not sure why it didn't this morning, but anyway, thank you for your time. I'll go ahead and sign off now.
Thank you.
Thank you. Okay, moving to our next item on the agenda. The meat of our agenda here is antipsychotics in children intervention update.
Okay, so good morning, everyone. Jennifer Strohecker here. Joe, Busby, and myself are going to co-present the next few slides that cover our work on antipsychotics in children. Several years ago now, it's hard to believe that our planning for this work began 3 years ago when, or maybe 2 years ago, maybe I'm wrong. Maybe my time frame's off, I'm sorry. But still, the foundation for this work did begin a couple years ago. And I know we've kept the board in the loop as we've moved along this pathway of developing a comprehensive approach to improving our management and oversight of the prescribing and use of antipsychotics in children. What we thought we'd start with in our presentation is to begin with some background slides, and actually the same slides that you've seen in prior presentations that really establish the framework of the approach we've taken as we've kind of built this policy. We know that the use of antipsychotics in children historically, and the evidence would show that they are used frequently in children, and that in fact in the United States, antipsychotics are used much higher, and among the Medicaid population, they are at the highest rates of use, including those in foster care, which of course have been an area of interest over the years. The challenge with antipsychotics, as we know, is they do produce some results. However, when used in children, they're often used off-label and may not be used according to any labeled instructions or for the right indications, and may be the first go-to therapies or used before other evidence-based and less harmful therapies have been tried. And there are risks. We know that antipsychotics are associated with movement disorders, certainly weight gain, metabolic changes, among other things that children may be exposed to when prescribed these medications. So as we began our approach, go ahead, Joe, if you would, move to the next slide. What we first of all knew, this was on our minds, and certainly something we had talked about as a team, but we were fortunate enough to have a Support Act requirement with the Federal Opioid Act, the Support Act. They embedded policy requirements and intervention requirements for Medicaid programs that were mandated to go into effect in October of 2019. So we actually did begin this work prior to that time. And the language was rather generic. They were looking for states to develop policies and interventions, and from that they would fine-tune the requirements of Medicaid programs. But in order to prepare and develop an approach that our patient population would benefit from, and also our stakeholders were in agreement with, we developed a stakeholder work group that engaged multiple individuals across the state, pediatric psychiatrists, specialists in the field, folks from the ACOs, and other public health entities, all joined us in multiple meetings as we went through various elements of interest. Our baseline goals of this work group were to, first of all, develop uniform policy recommendations for Medicaid patients. That being that we would implement policy that would be applied to both our foster and non-foster children, and that the goal of this was to promote the appropriate and clinically optimal prescribing of antipsychotics based on evidence-based literature standards, those that have been developed by, I believe, Florida and Texas, as well as published literature. And then we wanted to be carefully monitor and assess our progress as we implemented interventions, policy, and then use indicators, standardized indicators, to assess our performance along the way. So we can go to the next slide. We also used as our framework, go ahead, Joe, thank you, strategies to promote best practice antipsychotic prescribing. And I'm not going to go through this, but it's a systems-wide approach that really helped us look at various places of intervention and the opportunities that could exist. So we tried to be holistic in our approach and think comprehensively. And then again, as we have taken the approach with our interventions in pharmacy, the safety of the patient, even though we understood what best practice parameters may exist, we understood that there were certain folks who fell outside of these parameters. There were perhaps a high percentage of children at this point who may fall into high dose use or using more than one antipsychotic or perhaps even off-label use. And we wanted to be careful with our approach to make sure that when we implemented policy, that we were also allowing appropriate work with the providers so that they were aware of what was happening and that we were not cutting off any child from the medication that they were being prescribed. The other important piece of this is that we began working very, very closely. Actually, we worked closely with UPOP through this whole process, who have oversight of the foster care children, and their partnership in this effort has been critical, I believe, to our success in taking the right approach and in the implementation steps that we have gone through along the way. And so we'll talk more about that as well. And of course, we have representation from UPOP here today and have since developed a great relationship with UPOP in developing good quality recommendations. And as you know, we also have a psychiatrist on our Medicaid pharmacy team, Dr. Craig Hummel, who's also been a critical piece in advising us. So if we could move forward to the next slide. Some of the quality indicators that were used and identified early on were to use HEDIS standards of metabolic monitoring, the APM measure, the HEDIS APC measure, where there are 2 or more antipsychotics overlapped and used concurrently for greater than 90 days. Looking at published guidance around antipsychotic use in very young children and looking at labeled indications for young children. We also use the HEDIS APP measure, which is the use of first-line psychosocial interventions. We will not be presenting the results of that today. However, it is one that we are measuring. We've also established internal reporting trends, and Joe's going to walk through all of this data with you to share with you where we've come over the time frame since this has been launched. But we've looked at PA, prior authorization gathered data, peer-to-peer gathered data, and utilization trends through the point of sale system, so we can look at use among our different populations and age, sliced by foster and non-foster groups. I'll also note before we move into the data and the presentation on that we did make a requirement when we launched this policy to begin collecting diagnosis codes. So at the point of sale, we required that a diagnosis code be input on every antipsychotic prescription that is initiated in a youth, and that it's a requirement. We didn't delineate what those diagnosis codes should be. We wanted to keep it open to start and gather the data, and that is being evaluated as well. In addition to this, we've also established high dose edits so that high dose use, while that isn't necessarily a published HEDIS standard, it is labeled use indication to restrict or limit the use of very high doses in our population. This is applied to children and adults, and it hits a PA edit. So essentially the way that this works is, as we've been able to set up some of these metrics and implement the edits, we have always implemented a run-in phase of identifying the population that's going to be affected by a soft edit or a hard edit in our system. We do broad educational outreach, and then we do focused peer-to-peer outreach, letting the providers know, and this is an ongoing thing. And then that is a call campaign, letter campaigns, lots of one-on-one time with our pharmacist and our psychiatrist staff in educating providers, coaching them, working with them on best practice standards, understanding specific scenarios. Even today, that's done, and Joe will go into that work. When the edit goes live, we're careful with evaluating the prior auth as it comes in. and making sure we're promoting best practice standards. With that, I don't believe at this point, we've been doing this now for over 2 years, and there has not been any report of harm done to that's come to us with regard to individuals. While this policy has been implemented, you're going to see the numbers and has been changed over time. But no reports of patient harm, which is good. Many thanks to our work around the proactive work we've done and the approach we've taken. So I want to applaud the work of the team in their efforts to be thoughtful and proactive in working with the providers on behalf of Medicaid members. But with that, I'll transition over to Joe to show you the data.
So thank you, Jen. So before I show the results here of our work, if I can remember 3 things I want to mention. Number 1, first of all, this is a team approach. We are blessed with having fantastic pharmacy technicians. Our clinical pharmacists are also on this call to help with all of this intervention and the interfaces we have with providers mostly, but sometimes we do have interfaces with patients. So it's definitely a team approach to generate the results you're going to see. Second, I want to, like Jen did, call out special thanks to Jen for her leadership on this project, and to Dr. Hummel and Dr. Gargaro for all of their help on the clinical basis of helping with these, in many cases, very, very sick, very high acuity patients here. Third, I want to make clear that the approach that we've always taken with peer-to-peer is not that our providers are in the wrong, but exactly the opposite. They're all hardworking, they're well-intentioned. I can't think of a time where, when we've contacted them with this information, they have not appreciated it. They haven't. They don't respond angrily, but instead they're very, very thankful. They appreciate the data. A lot of times, we have access to data, for example, lab tests for these kids that they don't have access to. So again, I want to thank our providers and let you guys know that that's always our approach, to try to be collaborative with them versus punitive. So quickly here, as Jen mentioned, our goal was to improve, to encourage guideline aligned use of these meds. We pull our data mostly from pharmacy claims, although we do get, as I mentioned, some data out of our data warehouse on metabolic testing, for example. We're looking in this particular intervention at kids that are being given multiple antipsychotics, kids that are under the age of 6, kids that are on high doses of antipsychotics. And by way of background, with Dr. Gargaro's help, we use not only the prescribing information, age recommendations, but there's a couple of well thought of, peer-reviewed pediatric mental health guidelines on this, one from Texas, one from Florida. So we use those two, and we use the most liberal of all of those when we pick an age. We do provider outreach. We call them, we send them letters, we send them faxes, we adjudicate their PAs, etc. What we found is keys to success are that we provide each of our prescribers the information. Hey, here's the guideline, and here's your patients and their meds that don't meet that guideline. Okay, and then of course we measure it here. So let's, in the interest of time here, just a reminder that Medicaid has seen an expansion, Medicaid nationwide, but also here in Utah, we have got 16% more kids in Medicaid. So as you see these next numbers, we picked specific numbers of patients, not a percent. So, but keep in mind, there's this background of increasing number of children enrolled in Medicaid. Okay, over time here. So first of all, the total number of kids receiving antipsychotics for our total kids, so foster and non-foster, that number stayed pretty same, pretty steady. So it's not as if we're kicking kids off of these meds willy-nilly. Still a significant number are available. And what you're going to see here is the red line in this case is foster, and there's this showing a slight decline in the number of kids. But to Jen's earlier point, on a percentage basis, foster kids are far more likely to be medicated with antipsychotics than non-foster kids. So that's an important. This is again just raw numbers here. Okay, so number of kids under 6. So there's no guideline that recommends kids that age receive these medications. And what's happened is you can see we've had a decline of about 38% here over time. since we've been measuring this. And the UPOP managed kids, foster kids, they have no kids under the age of 6 that are receiving antipsychotics. So very, very good news there. For the number of kids that are receiving multiple antipsychotics, a decrease of 76%. Again, the foster kids, there's not any of them that are receiving multiple antipsychotics. In fee for service, we've got 4 kids that are still receiving it. We evaluate each one of those, and in almost every case, we get Dr. Gagaro or Craig's help to provide clinical insights on each one of those patients. Next, doses that exceed literature recommendations. So again, that's the package insert or these compendia recommendations. And we've had a nice decline of 41% in those cases in the number of kids exceeding these dose recommendations. Finally, of course, all of the guidelines recommend that these kids receive movement disorder assessments, which are a little tough for us to get at. But they're also supposed to get their glucose and lipids measured, and depending on the guideline, it should be 2 or 3 times a year. We simply look for one lab test that includes this in the most recent year of a child receiving antipsychotics. And this, unfortunately, we have not been able. It's gotten our UPOP fans, or I'm sorry, our foster kids are. Closing out on significant improvements. There, 40% of those kids are getting measured. Unfortunately, in fee for service, or all kids, were barely over 20%. So we could still show, need some improvements there. As you can see, it's 0.6%. Okay, so just the summary. Again, it's a team effort here. We do have some limitations to it. Sometimes we don't have good data. We've originally, for example, we were looking at the initial prescriber of antipsychotics. We've done better to say what's the most recent prescriber of the antipsychotics for the kids and contacted that individual. As we don't communicate with patients. As Jen mentioned, we have no reports of patient harm. That doesn't mean there hasn't been patient harm, but we have no reports of it. So the advantage of this, it's been effective, it's been well received, I'd like to argue, based on those results, and that this provides them clinically meaningful data. So I think that is it. Back to you, Jen, or others.
Yeah, I just wonder if Dr. Gargaro has any comments on this, and then we'll take any questions or comments from the board on the intervention.
Thanks. I just wanted to clarify, Joe, you were mentioning when you had the summary at the bottom of the slides in terms of the percentage decrease, that was looking at overall number versus like percentage of kids in Medicaid, correct?
Correct.
Okay, so
raw number, 10 kids down to 8 kids.
Okay, so even though we have more kids in Medicaid, with this intervention, we've still seen, for the most part, decreases in the total number on those medications, which I think is really
correct and
valuable.
You've said it better. You said it better than I did. That was the point I was trying to make. Is population's expanding, yet the raw number is declining.
Yep. And I think that's really valuable because one of the things that we know is that the metabolic side effects that antipsychotics have are more likely to occur in children. And be more significant because we also know from other data that overweight, obesity, metabolic disorders in childhood are likely to persist into adulthood. And this is already a really vulnerable population. And oftentimes, I think we find that when prescribers are using these medications outside of the guidelines, it's because they have a really challenging case with limited resources, and having the ability to engage with them and help connect either to resources or provide further education on updates regarding best practice, I think has been really valuable.
Thank you.
May I ask a question about that? To the issue of the non-pharmacologic cares, and knowing that those resources might be difficult to access for some of these families. Is that what it really makes the difference. I mean, we know that can be the preferred approach, but like other areas of medicine or other clinical areas, there's a default to pharmacotherapy when behavioral health is really the preferred approach. Is that what you would attribute some of the success here to, that, you know, getting those families to those resources?
Dr. Weinstein, excellent point. We are looking at psychosocial. We don't feel like our data is very good on that, so that's why we didn't report that, frankly. But I can tell you anecdotally, on our PA form for kids, we have you know, we ask, are kids receiving psychosocial? And the vast majority are. Last layer on top of that, I think, frankly, COVID with the telemedicine may have kind of been provided some additional resources to kids via telemedicine and telepsych services. So, you know, we're working on that. And yes, those interventions are needed, and we try to support those and make sure that those are utilized.
Yeah, I mean, I think I'm just, you know, I'm watching this from my long view is that, you know, we're all working on destigmatizing mental health care, and also working on making it more accessible. And to your point about, you know, the pandemic, we did see a pretty dramatic increase in telehealth services. So, you know, one of the positive outcomes of that was some, you know, creativity with expanding access. So I just wasn't sure, because I'm not as directly involved in pediatric care or in this arena, if that was also being seen. So thank you all for that.
And just one last
work.
Dr. Gregaro has been fortunate to be able to use her as a consultant. One of the wonderful things she brings to some of the very complex cases that we ask her to consult on are non-drug interventions. Hey, this child should be assessed via this way and that way, and, you know, perhaps this intervention is more appropriate than adding, you know, a third antipsychotic. Excellent point. Thank you.
Thanks, Joe. Are we ready to move on to the next agenda item here, which is Evkeeza? And I believe we have a presentation to start.
Hi, this is Scott Anderson from Regeneron. Is it okay if I give my testimony now?
Scott, would you please wait until the pharmacy team present the presentation?
I'd be happy to. Thanks.
Thank you.
All right. Hello, everyone. This is Luis Moreno with Utah Medicaid. And I'm going to present on Evkeeza. Can everybody see this presentation?
Yeah, Luis. It's a black
Right now, we
screen.
just see the duplicate of the meeting.
Oh, okay. Let's see here.
Looks like nesting dolls. No, there we go.
All right.
So present just the tab, Luis.
A tab, okay. And then it's not pulling up my presentation.
Or a window, I'm sorry, the term.
Okay. Try a window. Okay, there we go. How about this? Can you see it now?
There we go.
Okay, perfect.
Yes.
Very good. So, evinacumab, Evkeeza. And so this is a medication that has been approved. And let's see, how come it's not? There we go to the next page. There we go. It's been approved to treat the rare disease homozygous familial hypercholesterolemia, or HoFH. And it is an autosomal dominant disease, which occurs when mutations affecting cholesterol metabolism are inherited from both parents. When the mutations are inherited from one parent, then it is heterozygous FH, which is a less severe disease. But homozygous is more severe. Rare and life-threatening, occurs in 1 to 250,000 patients. It is the most severe form of FH because the LDL cholesterol can go as high as 500 to 1,000 milligrams per deciliter in these patients, with some patients suffering from an MI before reaching 10 years of age. So it's really sad because it does affect children. And the key point from this slide is being that statins and PCSK9 inhibitors, which are the big guns for cholesterol, to lower LDL cholesterol, usually are less effective to treat this condition because in the homozygous familial hypercholesterolemia, there's no or very little active LDL receptors. And so these statins and PCSK9 inhibitors act by upregulation of the LDL receptor. And so that's why they're less effective in this condition. And looking at what's in the arsenal for this condition. So we have statins, like I said, and, where in people that don't have homozygous FH, statins can reduce LDL cholesterol up to like 50% in some cases, most cases. And here it's up to 28%, reduction in LDL. And then if you look down at the PCSK9 inhibitors, in people without this condition, LDL cholesterol is usually lower between 40 to 60%. But in this condition, it's only about 23% reduction that is seen. And then we have other agents here, like ezetimibe, that reduce it even by less percentage points there. You see the novel treatment options, lomitapide, which is a microsomal triglyceride transfer protein inhibitor. And so it acts in a different pathway than the LDL receptor, and it can decrease cholesterol up to 50%. And then the one below, mipomersen, that one also acts in a different pathway, different mechanism than on the LDL receptor, and it lowers LDL up to 25% in this population. However, the problem with these agents is that they're both in the REMS program because of the high risk of hepatotoxicity with their use. So that brings us to, okay, what else? What else has been in the pipeline here for this condition? Because for these patients that their cholesterol is up to 500 or 1,000, they do need to reduce their cholesterol. Most guidelines recommend to reduce it to less than 100, their LDL less than 100 milligrams per deciliter. And for those who've already had an MI or CAD, then the goal is less than 70. And so that's why this medication, evinacumab, was designed to help further to make it easier to reach those targets in this population. So what is it? Evinacumab is a human monoclonal antibody, and it's also a I can't even say this, angiopoietin-like protein 3, there we go, or ANGPTL3 inhibitor, which leads to the reduction of LDL, HDL, and triglycerides. And what is this ANGPTL3? So it is thought to play an important role in lipoprotein metabolism because it reduces LDL independently of the LDL receptor, unlike statins and PCSK9 inhibitors. It inhibits some enzymes called the lipoprotein lipase and endothelial lipase. And these guys are involved in the degradation of triglyceride and triglyceride-rich lipoproteins like VLDL. And so that's how they're able to lower when we inhibit this A and GPTL3, then that's why LDL is reduced, and also HDL and triglycerides. And it became a pharmacological target of interest because there were some investigations done, and they saw that patients with loss of function of this loss of function mutation of A and GPTL3 had a 34% reduction in the odds of CAD and reduced plasma levels of triglycerides and LDL. So that's how people became interested in this evinacumab as an inhibitor of A and GPTL3. So now let's move on to the ECLIPSE HoFH study, which involved studying evinacumab. And this was a randomized placebo-controlled trial, double-blind, which involving 65 patients total. And they ranged in age from 12 to 75 years old, with the mean age being 42. And they had diagnosis of HoFH, and it was established via genetic testing, or these conditions listed here, such as history of untreated total cholesterol greater than 500, and either xanthoma before 10 years of age, or evidence of total cholesterol greater than 250 in both parents. And so placebo was merely background therapy of statins, which 94% of the patients were on statins, ezetimibe, PCSK9 inhibitors, lomitapide, and lipoprotein apheresis. And then the control group, they added evinacumab to that. And even though with this extensive background therapy, the mean baseline LDL was still 255. So as you can see, it is very difficult to treat this patient population. 43 patients were randomized to receive evinacumab, and 22 patients randomized to receive placebo. And the dose was 15 milligram per kilogram IV every 4 weeks for 24 weeks. And the results, primary endpoint was mean percent change in LDL cholesterol from baseline. And so they were to see a 49% decrease in cholesterol in those that were taking evinacumab compared to placebo. And that was significant. And as you can see in this table, it's showing other markers such as ApoB, non-HDL, total cholesterol, triglycerides, and you can see a significant decrease in all of them. HDL, there was also a decrease in that, and that was kind of a safety target that they were analyzing. And HDL did decrease by about 30% in those taking evinacumab, compared to a 1% increase in HDL in placebo. Contraindications, history of serious hypersensitivity reactions to evinacumab. There was anaphylaxis reported in 1 patient receiving the medication, and those are the list of common side effects there for you. In terms of special populations, females of reproductive potential, it is recommended that they get tested for pregnancy in patients who would become pregnant prior to starting evinacumab. It was found to be teratogenic in rabbit studies. And so that's the recommendation there, to do pregnancy testing in those of reproductive potential. And then for those who are already pregnant, females already pregnant, then to advise them as to the risk to the fetus. Place in therapy. So as in the study, as in the ECLIPSE study, it is recommended first statin, and then add ezetimibe and a PCSK9 inhibitor. After that, lomitapide or mifepristone, which are adjunct. But again, the limitation there with these agents is that they are very hepatotoxic. And so they both have black box warnings for that. And they are not very heavily used. And then the fifth option there is our agent that I'm presenting on, evinacumab, as kind of the last resort. And final points for PA criteria. It is indicated as an adjunct for the treatment of HoFH in patients greater than or equal to 12 years old. It is unknown if it is safe and effective in people with other causes of hypercholesterolemia. Patients who may fit the FH clinical picture should be referred to a lipid specialist, and then also consider the potential for teratogenicity. And so consider pregnancy testing in patients who may become pregnant prior to starting this medication. Advise patients who may become pregnant to use effective contraception during treatment and for at least 5 months following the last dose according to the package insert. And in pregnant patients, discuss the risk of harm. And that is the end of my presentation. Let's see here. And so with this medication, because it is, HoFH is a rare disease, and we've looked at pharmacy claims from the time that it was approved back in February of this year till now. There are no pharmacy claims for that. There are no prior authorization requests for it. And so we did come up with a PA criteria for this medication, but then talking about it and its utilization so far, it might make better sense to recommend it for to be as a rare disease prior authorization, that providers can request it through that PA form instead of its individual form. But that's the recommendation. Any questions, comments?
Hi, everyone. This is Scott Anderson, and I work for Regeneron Pharmaceuticals. I just want to say that was a fantastic and comprehensive review of Evkeeza. I don't have anything to add, but I'll just make myself available if anybody has any questions for the manufacturer.
Thank you, Scott.
Thank you, Scott.
My understanding is it's currently only approved for the homozygous familial hypercholesterolemia, not heterozygous familial hypercholesterolemia.
That's correct.
Are there ongoing studies showing whether it will affect cardiac outcomes? Because from the data that I see submitted, it doesn't appear that the studies that have been done to this point have really shown that outcome.
That's correct. This is Scott again from Regeneron, and if it's okay, I'll take that question. You are correct. There are not studies that show sort of outcomes on cardiovascular disease. The problem that we have is that it's very difficult to recruit these studies because of the patient population is so small. So for us to get an adequate sample size, it's very difficult. The phase 3 study that led to the approval was only 65 patients total, and that was a worldwide recruited study. For us to be able to enroll enough patients to see cardiovascular outcomes, it's just very difficult.
Any more questions from the committee, or are we ready to make a motion?
I think we're ready for a motion.
Kumar, do you have your hand up? No.
Well, no, after listening to the discussion, I propose that, we approve for the time being, and by that I mean, 6 months from now or so, we need to get some results and see if it is continuing to be safe and useful or not. That's my motion in a roundabout way.
Okay, are you saying we should go with the recommendation to use the rare disease prior authorization as well?
Right.
Okay, sounds good. Is there a second on the motion? Second from
Second, yeah.
Thank you. Any further discussion? All in favor of the motion on the table, say aye.
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 Aye. Any opposed? Abstentions? Okay, sounds good. Motion passed. All right, so looks like that's it for our agenda, with the exception of a reminder about the next meeting, Thursday, August 12th, where we'll be discussing teplizumab. Anybody have any other comments they want to share before we adjourn?
Motion to adjourn.
Sounds good. Is there a second? Second from Kumar. I see you there. Okay, all in favor of adjourning, say aye.
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 All right. Thank you, everyone, for coming, and I'll see you next month.
Thank you.
Thanks.